Assalamualaikum and good day everyone. My paper title Efficacy of Concomitant CRYOMAZE Procedure in Patient with Persistent Atrial Fibrillation. The study was conducted in University of Malaya Medical Center. The CONCOMITANT procedure was developed by James Cox and introduced clinically in 1987. It involved cut and sew procedure in right atrium and left atrium to eliminate the atrial fibrillation while allowing the sinus impulse to reach the atrioventricular node. First version of COXMAZE was complicated by late chronotropic incompetence and a high rate of pacemaker implantation. The COXMAZE procedure underwent two further modifications, eventually resulting in the COXMAZE 3. However, it does not perform regularly because it is tedious, prolonged surgery, and risk of bleeding. While COXMAZE 4 replaced the cut and sew technique with lines of ablation created using bipolar radiofrequency and cryothermal energy devices. It was introduced clinically in 2002. The use of ablation technologies made the CRYOMAZE 4 technically easier, faster, and more amenable to minimal invasive approaches. This picture shows the evolution of COXMAZE 1 to COXMAZE 4. Cryoablation uses cryothermal energy devices to induce cell necrosis, which happen at negative 30 degrees Celsius. The key for successful ablation is transmural fibrosis. Cardioblade cryoflex use argon-based gas and reach negative 150 degrees Celsius in a short period of time. Cardioblade cryoflex surgical ablation probes are distinctly millable, allowing them to be easily shaped and reshaped by hand to address varying tortuous anatomical situations from multiple surgical approaches. This picture shows the CryoBlade CryoFlex systems where the console which houses the argon-based gas and the probe, and as you can see the probe is malleable to accommodate during surgery. COXMAZE 3 have a high freedom rate from symptomatic atrial fibrillation at 5 years. COXMAZE 4 also have almost the same result with the efficacy of about 90% of freedom from atrial fibrillation. The MAZE procedure is unlikely to be successful if the patient has left atrial of size of more than 5 cm, long-standing atrial fibrillation more than 5 years, and advanced in age. The objective of the study is to identify the efficacy of concomitant CRYOMAZE ablation in patients with persistent atrial fibrillation who underwent open heart surgery. To examine the factors that contribute to failed CRYOMAZE ablation. It is a retrospective study. Patients' medical record who had a concomitant CRYOMAZE ablation during open heart surgery in University of Malaya Medical Center between 2018 and 2020 were reviewed. 11 patients with persistent AF had a concomitant CRYOMAZE procedure done during open heart surgery. The average LA size was 5.1 and the average duration of atrial fibrillation was 18 months. Among 11 patients, 9 were successfully followed up. 1 passed away post-operatively due to sepsis. 1 patient lost to follow-up. A mean follow-up of 10 months was recorded. Among the follow-up patients, which is 9 patients, 8 had successful ablation, which contribute to 88.9%. Patients who failed the ablation had LA size of 6 cm and had a duration of atrial fibrillation of 3 years. As for conclusion, concomitant CRYOMAZE during open heart surgery has high success rate when treating patients with persistent atrial fibrillation. With that, I end my presentation. Thank you.